Everyone, and welcome to Talking Point. My name is Vic Manning. I'm a Professor of Addictions at Monash Uni and Head of Research and Workforce Development at Turning Point. And I'll be facilitating today's Talking Point presentation by Professor Nadine Ezard, which is on a really exciting trial with a hot off the press paper published in Addiction on Lisdexamfetamine in the treatment of methamphetamine dependence. I'd first like to begin by acknowledging the traditional owners of the unceded lands on which we all come together today, and pay my respect to their elders past and present, and extend that respect to Aboriginal and Torres Strait Islander people listening today or in the future. So Talking Point is a regular series of publicly available lectures that aim to inspire, inform and challenge our notions of what we know and think about addiction and its impact across society. We really like our webinars to be as interactive as possible, so please ask questions via the Q&A function. I'll collate those and they'll hopefully be answered by Nadine at the end of the presentation. Our webinars are recorded and they're made available usually within a week or two on the Turning Point website. So I'd like to introduce today's presenter, who we are very fortunate to have. Dr Nadine Ezard is an addiction medicine specialist and a founding fellow of the Australian chapter of Addiction Medicine. She's a professor and the inaugural director of the National Centre for Clinical Research on Emerging Drugs with the Faculty of Medicine at the University of New South Wales. Also, since 2012, she's been the clinical director of the Alcohol and Drug Service at St Vincent's Hospital, Sydney, which serves people with a variety of substance use disorders in inpatient, outpatient and community settings and strives to embed innovation into practice. Previously, she worked at the WHO, the United Nations High Commissioner for Refugees, and the United Nations Office of Drugs and Crime. Now, Nadine has more than 30 years of clinical and research experience in addiction medicine and public health practice in Australian and international contexts. She's a worldwide recognised researcher in substance use and its translation into consumer-focused harm reduction public health interventions, models of care, and policy for vulnerable populations. Her current research focuses on working with people who use stimulants and related drugs to develop new and effective interventions, and she has a particular interest in substance use disorders among refugees and other displaced populations. Thank you again, Nadine, for coming today to deliver today's Talking Point. I'll now hand over to you.
Great. Thank you, Vic, and thanks to Turning Point for hosting not only the series, but for hosting me here today. I'm really pleased to be here. As Vic said, really keen for this to be a discussion and for people to put questions up, because this is our opportunity to think through how we can do things better and differently. So please bring those questions on, and hopefully we'll have time at the end to discuss them. So as Vic discussed, I'm going to talk about a randomised controlled trial we conducted across a number of sites looking at a drug called Lisdexamfetamine for the treatment of methamphetamine dependence. The work was conducted on unceded lands of Gadigal people, Awabakal and Warramite people, Bunurong and Wurundjeri people, and Kaurna people in South Australia. And I'd just like to acknowledge that unceded land and pay my respects to Elders past and present and all First Nations people who participate in the study, as well as all the other participants, and particularly the anonymous client who suggested studying Lisdexamfetamine for methamphetamine dependence in the first place, and the study nurses and research team members. The study was funded by the NHMRC, and NCRED, which is my institution, is funded by the Australian Government Department of Health and Aged Care. I'm employed by St Vincent's, but I don't have any other conflicts to declare. This is a work of many, many people, not only the investigators, not only the participants, but also a number of investigators who are there on the screen. And I want to particularly call out Nicholas Linzeris, who's the senior investigator on this trial. I'm not going to go into too much detail, but we know that there are millions, many millions of people who use methamphetamine around the world. And actually the number of people using methamphetamine and running into problems with their methamphetamine use is growing around the world. And the use of methamphetamine is really spreading globally. And for some people, it can be associated with some quite significant physical, psychological, social harms, and also increased mortality. Not everybody who uses methamphetamine will have a disorder. Not everybody who uses methamphetamine will seek treatment, but there are increasing numbers of people that are coming forward and asking for some sort of support. And at the moment, we don't have a lot to offer other than counselling, and certainly there is some evidence for effectiveness of psychosocial treatments. Pretty much they're all equally as effective if you participate in them. And pretty much as soon as you stop participating in them, the effect wanes. And that's been summarised in a recent Cochrane review where all the evidence is summarised and examined, and that's kind of the conclusion that people are coming to. In contrast to other substance use disorder, there's no pharmacotherapy or medication that we can really offer people. One of the promising directions for treating stimulant disorders substance use disorders in general, is to use a substance with quite similar properties. So that we call them agonist therapies, if you like. And the rationale behind using them is that they might be a safer dose or a safer route of administration, have fewer adverse effects. And we know that for other drugs like opioids and nicotine, that it can help people to reduce or stop the use of the drug that they're trying to change their relationship with. And the theory behind that is that it does sort of two things. One is that it attenuates the negative reinforcing effects. So treating those kind of withdrawal symptoms so that the driver for use is to treat the withdrawal from when you stop using. And the other is that with that particular substance on board already, when you use on top, you don't get the positive reinforcing effects either. So it's sort of, the theory is that it works on both those arms of the drivers for maintaining a use disorder once you've developed it. The other thing is that if we have something to offer people, we also have a framework for regular healthcare and psychosocial interventions and other supports that people might need. The drug that we selected to use is Lisdexamfetamine, which is a prodrug of dexamphetamine. And we've been using dexamphetamine off-label here in New South Wales for many years now, and there are other countries as well where it's been used off-label, as in not for the indication that it's approved, but for this indication, so it's stimulant use disorder. The advantage of lisdexamfetamine is that it's converted into dexamphetamine in the red cells. So it has a much slower onset of action than immediate release dexamphetamine and a longer duration of action. So that you can just have it once a day. And it's already licensed in Australia for the treatment of attention deficit hyperactivity disorder, as well as binge eating disorder, to a maximum of 70 milligrams. Now, that's important because that's the dose that you use in kids with ADHD. So it's obviously not going to be, well, we theorise it's not going to be enough for someone who's using methamphetamine every day in the dose range of 100 to 500 milligrams, which is typically what we see, although some people use a lot more than that. Theoretically, because it contains no free dexamphetamine, if somebody crushes it up and injects it, it still doesn't have a faster onset of action. So it doesn't have that positive reinforcing effect because it still has to be metabolized in the red cells into dexamphetamine. And when they've done studies with people that have injected it, lisdexamfetamine compared to dexamphetamine, it's just not as exciting. And so the conclusion is it's less abuse-related liking. I know that's not a term that I use, but that's the term that they used when they were studying it. And so then also theoretically that then the regulators may be more willing to allow a less controlled environment if this did work. So if you're thinking about a drug like methadone that needs to be picked up every day, daily supervised, that's not so convenient for some people that have been trying to do other things with their lives, so that this drug, lisdexamfetamine, may be more attractive to regulators than dexamphetamine in terms of the controls around it. So based on all of that, we did do a pilot of lisdexamfetamine up to 250 milligrams a day in people who are dependent on methamphetamine, and we saw no real safety concerns at that dose in that group of people. It was just a pilot, so we weren't looking at whether it worked or not. So then we were fortunate enough to get funding to do a multi-centre randomised control trial, and what we looked at there was to test the efficacy and safety of 250 milligrams a day orally of lisdexamfetamine for 12 weeks, and we looked at whether it reduced methamphetamine as well as other health and wellbeing measures. And this was conducted across 6 outpatient clinics in Adelaide, Melbourne, Newcastle and Sydney, bridging the COVID time, which is relevant when I come to it. So from 2018 to 2021. And the people had to be reporting at least 14 days use out of the previous 28. And the reason we set that threshold is because we know that the existing interventions, the psychosocial interventions, have less effect for people using more frequently. And also theoretically, exposing someone to a prescribed high-dose stimulant has known effects, particularly hypertension and risk of psychosis. And ethically, it would be we thought unethical to expose someone to a daily high-dose stimulant if they weren't already exposed to a daily high-dose stimulant. So the intervention, we had quite a rapid induction period, 150 milligrams a day, and I think we can talk about this in the discussion, but most people had no adverse effects at that dose, and I query whether people could actually start straight at 250. But we started at 150 based on our pilot data, and then weeks 2 to 13, people got 250 milligrams a day, and then reduced over the subsequent 2 weeks. But the primary endpoint there was at week 13, so after 12 weeks of the medication. At the same time, we offered a manualised 4-session cognitive behavioural therapy as best practice, like a social intervention. That was the Amanda Baker intervention, and that was offered to all participants. Eligible participants were then randomly allocated to either lisdexamfetamine or an identically matched placebo. And the study visits pre-COVID were daily attendance for 5 days because we wanted to check to see if people were having any problems with the investigational product, and to make sure people were comfortable with the procedures. After COVID, because we had to pause during COVID and had reduced contact because of the public health measures, and then after COVID, we had a protocol amendment and reduced that just to the first 2 days, and then contact by phone after that. The maintenance period, people had twice weekly supervised medication and then home consumption provision for the other days. 2 times a week urine drug screen, of which 1 was selected at random for testing, and the reason for that was for cost, because the urine drug screens are expensive. We conducted pill counts and medication adherence counselling, and safety measures, adverse event recording. After COVID, again, we reduced the frequency of those visits, so it was only once a week observed dosing and 6 times a week home dosing. We had long visits and medical reviews once a month, and then a follow-up at week 19, and everybody was reimbursed in an increasing schedule, from $20 increasing by $10 a week to weeks 1, 5, 9, 13 and 19. And it's interesting that this is already the protocol was written 8 years ago or so, and now we do recognise that those reimbursements need to be greater, and I think if we did it now, they'd be much larger amounts. So the primary measure that we had was past 28-day self-reported methamphetamine use using the timeline followback at the end of the 12-week intervention period. And that's important. So that's the part, so the end of treatment past 4 weeks methamphetamine use. So just the last 4 weeks of treatment. We also looked at safety, and then we had a whole lot of secondary measures. So one of them was the methamphetamine use over the whole 12 weeks, the longest period of self-reported abstinence, continuous 21-day abstinence, and percentage of methamphetamine negative urine tests over the whole 12 and the last 4 weeks. Then we looked at retention, craving, withdrawal, physical and mental health, treatment satisfaction, non-medical use liability profile, and use of other substances. 164 people were randomised. 155 of those received at least 1 dose and were included in the final analysis. Only 100 were retained to week 13, which is again important, and 89 of those retained on the medication. You probably can't see the flowchart there, but the main reason for dropping out was that people just were unable to be followed up. In terms of the people who agreed to enrol in the trial, they're around 40 years old, so what we would expect clinically, but obviously not an early intervention from a public health perspective. We had, a 60-40 split, a male to female. You can see that so we used the Wendy-Utah rating scale, and we used a cutoff of 46. Both of those things are for symptoms of ADHD in childhood. So it's not about current symptoms, which often overlap with symptoms of methamphetamine use disorder, but it's about whether people may have had an ADHD, been able to be diagnosed with ADHD as a child. And that's around 40% of the sample, which is greater than the general population, but maybe not greater than a substance use treatment population. This is relevant for later, and I'm sure it'll come up in the discussion. You can see that this was a group of people that were using almost daily, so mean 24 out of 28 days. The age of first use was around 22, so you can see people have got like 18 years of regular use before they're coming for this trial. And around half were injecting, and the severity of dependent score mean was 10 overall. And I think people are aware that 4 is the cutoff for a screening positive for a methamphetamine use disorder. Oh, sorry, just need to go back. Yes. So this is kind of the summary slide, if you like. Placebo group, and the orange line is the lisdexamfetamine group. And you can see that by week 13, so that's the past 28-day use at week 13, the two lines overlap. So it's only very weak evidence of a benefit of lisdexamfetamine at that point of around 2 days. And the p-value is, you can see there, the p-value is 0.49. So it's only very weak evidence of difference at that point. But if you look over the whole 12 weeks, you see about a 9-day difference in use between the two groups, which is statistically significant, not the primary outcome that we chose a priori. And also there's a question that I would love us to discuss at the end about the clinical significance of that change in frequency. In terms of safety, we saw serious adverse events in 4 participants receiving the active and 3 participants in the placebo. The adverse events otherwise were mostly mild to moderate, and the only one that we saw that was different by group was that there was more nausea in the lisdexamfetamine group. We saw no concerns in terms of heart rate or systolic blood pressure. There was a tiny difference in diastolic blood pressure at 2 time points that I personally don't find concerning. This is the retention, and recall again that we were impacted by COVID, so we had to actually pause the trial at a certain point to recruitment and then restart up again after the COVID public health interventions. And there were at the same time secular changes in methamphetamine availability and use, so it does traverse to quite distinct time periods in the Australian context. Nonetheless, we did have quite some dropout, but we saw no dropout difference between groups. The other outcomes that we saw that I think are important is the lisdexamfetamine group really reported that the treatment was effective much more than the group that received the placebo, and that they liked the drug more. So that's important. And again, this is when we come to talk about what outcomes we should be using in our trials. These participant-reported outcome measures are really important because we're working with participants and we're trying to help people achieve what they want to achieve. So I think that's important. The other thing that's really striking is that was very poor attendance at the cognitive behavioural therapy interventions. There was a mean of 1 session per participant. It was quite a broad range of people attending for none or 4, but the mean was 1, and it was the same in both groups. So the rationale that this intervention might help adherence to counselling didn't really bear out in the study, and there was no other significant findings to report there. I've already mentioned COVID. We did perform a post-hoc power analysis, and we were powered to 65% to detect a between-group difference of 4.5 days on the primary outcome. So you can see that we weren't. The limitation in all of these studies to date internationally are usually underpowered and high dropout, and we experienced both of those things. This was not atypical. The other limitation for some people is the use of the primary measure of self-reported days of use. Again, this is a conversation we have to have collectively. What are the best outcome measures that we should be doing in these trials? The other limitation was that the people allocated to the lisdexamfetamine were more likely to guess that they were on the correct medication. So there was some question about how well it was blinded in that respect. So we concluded that lisdexamfetamine did lead to a reduction in days of methamphetamine use over a 12-week period, but only weak evidence that this was maintained during the last 4 weeks. So the practice implications from this for me is that it's cautiously consistent with the recent guidelines from the American Society of Addiction Medicine and the American Association of Addiction Professionals in the States, where they recommend closely monitored psychostimulant prescription by specialist clinicians. And I would say that this does suggest that we should be careful when we're doing this off-label prescription, that if we don't see any response within the first 4 to 8 weeks, then maybe this medication is not going to help people. So we do need to add that close monitoring. I do think we can confidently conclude that lisdexamfetamine at higher doses than approved for other indications like ADHD appears well tolerated and liked in this group of people who are using methamphetamine almost every day. We did not stratify by childhood ADHD status, so we could not see a difference by ADHD was positive or not, because we didn't have sufficient power. So that's a question that we need to look at going forward. And I've already mentioned that we need to talk more about what the clinically meaningful outcome might be. So this is the paper. If you want to look it up, it's all in there. There are a couple of commentaries based on, in response to that might be interesting to look at. So one is around the kind of role or place of agonist therapies for stimulant use disorder. And the other is suggesting that we also need to have a look more in detail about where to go next with that, really. So now I'd really like to open up to comments and questions. I can't see them on my screen. So Vic, I don't know if you have them or if you've got any questions you want to ask.
Yeah, thanks, Nadine. Yeah, please send your questions through. Thank you so much. I just want to congratulate you and the team on such a high quality trial and the success that you had despite all of those challenges during the COVID years. You know, it's brilliant that you managed to get as many people as you did and the follow-up rates that you did. There's so much that we can learn from this study. It's really fantastic work. Thank you for presenting it. I'm keen to discuss the clinical meaningful outcomes as well, because, you know, it strikes me that reducing by 9 days of use in a population that have pretty heavy methamphetamine use at baseline is, you know, we know that reductions in use are associated with health and well-being benefits. So it seems to me that is, whilst it wasn't your primary endpoint, that's still a really meaningful outcome. I think it's probably underestimated if you think about the placebo group, who we know when we run trials like this that people often enter trials when they're most motivated to reduce their use. They're having contact sometimes with researchers or clinicians that they wouldn't normally have. There's often the expectancy effects, the placebo effect. So the control group often reduce much more than they would ordinarily, right? So that 9-day difference between the two groups is actually quite significant.
Thanks, Vic. I don't know if you can see that. I've put on the screen again exactly that slide that does reinforce exactly what you're saying. We did see a decrease in both groups. So it's as you said, when people enter a trial, often everyone reduces their use, and we can see that slightly increased reduction. So you can see that the reductions were quite important for both groups. So the benefit of being part of the trial is probably there as well.
Yeah, which means if we were comparing it to, say, a waitlist group, the reduction would have been, you know, in a much exaggerated, not exaggerated.
I don't know. We didn't do it, so I don't know.
Yeah, that's what I'm saying. I think in terms of clinically meaningful, is it a clinically meaningful reduction? You know, it's kind of that we're comparing it to a high bar in that sense when we've got a placebo medication.
Yeah, I mean, I think 24 to 14 days is quite a big difference for people. So, yeah. So, but to me, also the fact that people that received the active and they didn't know they would necessarily receive the active, liked the drug and said it was effective. So that's also important to listen to, I think.
Yeah, but we see this time and time again, right, in drug trials, that the placebo group show quite marked benefits. And, you know, often it is the other factors, the contact with the regular check-ins that they wouldn't necessarily be getting otherwise if they were not in the trial. So not much we can do about that, unfortunately. There's no perfect design.
Well, I think that's why we do we do a placebo-controlled, randomised controlled trial to exactly tease out those differences.
Yeah. But I mean, I guess when we're delivering a placebo, they may still be getting more contact than they would if they weren't in a trial, you know, what their reductions would normally be. Yeah.
Yeah, but we need to know what, you know, given the risk of any medication, the additional benefit of having that drug is.
Exactly. So on the basis of the fact that there was a reduction, albeit not at the primary endpoint, but in those initial 12 weeks, and the participants felt that it was more effective and they were satisfied with it, would you recommend it as an option? Do you think it should be prescribed as an off-label use?
So as I concluded, I think there is cautious support for using it off-label by specialists, prescribers in a comprehensive treatment context with close monitoring, partly for the side effects, but also to see if there's any improvement. But it is still off-label; it's not approved, but it does have cautious support for those conclusions from at least from the US guidelines.
Yeah. And if you can speak to any sort of similar studies, any replication type studies, or any other studies overseas that have looked at this medication since? Or
So there is a trial going on in Norway looking just at dexamphetamine, not lisdexamfetamine, because of the cost of the medication in people with opioid use disorder or opioid dependence. And there is another trial being conducted in Canada by Didier Jutres, who's looking at lisdexamfetamine alongside contingency management. And this is, I think, when we're looking at adherence to the trial procedures, we only gave that little $20, $30, $40 voucher for participating in the research interviews. But I think we need to be moving towards some sort of contingency management component as well. And that trial is interesting because the sites defined what they were going to reward. So it wasn't necessarily urine drug screens that were negative for methamphetamine. It might have been participating in a needle syringe program or participating in counselling or whatever the sites decided. So that's a really interesting study and a really interesting side component. And actually Didier will come to our NCRED symposium in November, on November the 9th. So that's the afternoon before APSAD, if people are interested to hear more about that approach in his study. And I'm pretty excited by that.
Yeah. Thanks for that. There's a few people asking we'll put the link with the recording when we send that out, but otherwise it can be found in Addiction. It was in the last issue, wasn't it? Well, most recent issues, the paper?
Yeah, the July one.
And so somebody's asking, what was the serious adverse effects?
I knew you were going to ask me that.
Cardiac?
I think off the top of my head, it was someone who had a relapse to their bipolar disorder, because we had a real life inclusion criteria. So people would come in as long as they're well enough to consent. But it was a real life, it was a relapse to the bipolar disorder. So not, could potentially have been related to the medication.
Yeah. And what's the half-life of lisdexamfetamine?
It's about 12, 14 hours.
No, it's okay. Somebody's asking, I don't know if you can see the
I can see the questions. Do you want to start from the top? Currently in Western Australia, SH prescribing codes limit the use of lisdexamfetamines within the approved diagnoses. Very interesting question. So this is the regulatory environment, and it's true. The New South Wales Health has for quite some time, under the auspices of a stimulant treatment program, provided short-term 6-month permits to prescribe for stimulant use disorder under very strict criteria. You need a second psychiatrist opinion, you need to have close monitoring, you need to have daily supervised dosing. So that's for both dexamphetamine and lisdexamfetamine, and that's a local administrative arrangement. Obviously, it's not subsidised by the PBS, so the patient or client has to actually pay their own medication and dispensing costs, so there is a cost barrier. But in terms of the regulation, the New South Wales Health Government will provide a permit to do that. We did manage, the sites were South Australia, Victoria and New South Wales. Obviously, in a trial condition is completely different. I don't think in the other states they have that option to continue the prescribing afterwards for this indication. So I think this might be where New South Wales is distinct. There's nothing, that doesn't mean that it does just require a discussion with the local health authorities about whether they think there is sufficient evidence to use this as off-label treatment. And there's a lot of off-label prescribing in many sectors. I'm not arguing necessarily for it, but there is maybe a scope there, but it would require some sort of leadership and discussion with the authorities. But the cost, the lack of support with subsidised medications from the PBS is the bigger hurdle. So we do need stronger evidence before anything like this will be more widely available. because the research is just the first phase, and then you actually need the medication to go through the whole TGA and then the PBS process. Did Nadine say that any more than 14 days out of 28 days of methamphetamine use results in non-effectiveness? Oh, so the evidence shows that the psychosocial interventions are the effect is usually greater. This is in secondary analyses, greater in people using fewer than 14 days out of the past 28. So it doesn't say it's less effective in more, but it shows it's more effective in less.
Yeah, and just related to that, why do you think there was such little attendance or uptake of the CBT here?
My theory, and we don't know because we didn't ask people, my theory is that we selected out a group of people that were looking for a medication treatment. Right. So people had already tried many of the other available treatments, and they were looking for a new treatment, a medication treatment for this. That's my theory, but we didn't actually ask them.
I did wonder if they might be involved in other forms of counselling or something. The next ones we've sort of touched on: adverse effects, half-life. Did it reduce the amount of consumption? Was this studied or possible to?
So we did just use frequency because the timeline followed back is validated for days of use, not amount of use. We did ask people how many points they were using, but we haven't done that sub-analysis yet. And I'm not sure how valid that's going to be because there's a lot of variation between purity and between what a point is. Very few people weigh and have access to measuring the purity of their medication, so of their methamphetamine. So I don't know how helpful that's going to be, but we can have a look at that and see if it suggests anything. I know that our Norwegian colleagues are actually using that as their primary outcome rather than simple frequency. They're also doing a dose measure, so they're doing a mixed frequency and dose, so an intensity measure. So it'll be interesting to see what they come up with, but it hasn't actually been validated. And this ties in with the bigger discussion about what is it that we're trying to do? What's the most important thing we're trying to do? And how do we have that conversation to make sure we're measuring what people who are coming for treatment want?
Yeah. We might come back to Prince William's question because I'm hoping you might talk to Olam at the end. But the next one is around the difficulty of finding a prescriber. If you can see Demetra's comment there.
Very hard because that's the problem. That's why we're doing all this in a trial environment. So getting access outside of a trial context is really difficult. And again, I don't want to promote the use of non-evidence-based treatment. So when we talk about off-label treatment, it is really individualised and not based within a scientific evidence base. So really, we need to be pushing the research base, but finding people who are prepared who are able to prescribe psychostimulants to people with stimulant use disorder. We've already heard that it's mostly constrained in most states. The other kind of part of that is that I do think that we are under-treating ADHD. We know that ADHD is more prevalent in people seeking treatment for substance use disorders than in the general population. And it's an area that we need to explore because often treatment with psychostimulants for people with a stimulant use disorder and coexisting ADHD is even harder to access because people are not trusted with their medication, if you like. So there's an additional barrier for treating some of the other coexisting disorders. And I think the ASAM guidance that I mentioned before really mentioned that quite strongly as well, and the importance of treating coexisting conditions as well.
Yeah, and monitoring changes in those. Yeah. Naomi's asking if there has been much involvement of lived experience to sort of get to what is a meaningful clinical outcome for this particular project.
Yeah, and I think we'll come to the Olam trial next in terms of consumer engagement in a very formal and comprehensive way. But there is a piece of work that we do need to do with people with lived and living experience and consumers of health services, as well as clinicians and healthcare providers, try and tease out what a clinically meaningful outcome is for everybody. And that there are already many different outcome measures in place, and some of those are definitely informed by or driven by people with lived and living experience. But in terms of what a primary outcome measure for a research study is, with what purpose? Is it for the purpose to get it registered in a government formulary. So I'm thinking, for example, in the Netherlands, they need to, when they're going for their trials, they actually need to look in the future to what evidence might be required to actually have that medication registered with the government. And increasingly, the governments there are saying we need to have lived and living experience indicators, we need to have wellbeing indicators in there, or we don't want to have anything to do with it. So it is kind of a moving piece, but I do think we are moving a little bit towards trying to do better in that space.
Fantastic. Liam's asking about, is it something only addiction specialists prescribe off-label, and what the price would be to consumers?
Yeah, so some of them might, but it does depend where they are, because they need to do it within those regulatory environment. So it is very constrained, and the cost for dexamphetamine is not a lot for the actual medication, because it's a non-generic, it's a generic medication, but you need to pay the dispense fees in the New South Wales context. Lisdexamfetamine unsubsidised is very expensive. It'll be about $100 for 4 days just for the medication, and then you have to find someone that can do the prescribing and do the counselling as well. And so this is not yet really broadly available, and I'm not even arguing for it to be broadly available, because I don't think the evidence is strong enough yet.
Yeah. We might go to Prince William's question. I mean, there's somebody here who's asking about future studies, but also noting that there's somebody who's wanted to get off meth, and waiting for this to become more mainstream, that acknowledging the stigma that's there from healthcare professionals. I'm counselling and CBT, but I feel like syphilis. So
yeah, I'm sorry.
Yeah. So going back to the first question, which was around, what studies are coming next, perhaps with new participants, we're not in COVID, different measures, different context.
So as you mentioned, we are about to start, and I think we'll have the first participants in the coming week or two, a study using lisdexamfetamine for withdrawal. So that's a different thing. So withdrawal isn't treatment. Withdrawal is something that you need to go through when you're changing the frequency or stopping methamphetamine use. But often what people tell us is that if you're using a lot and then you stop, you crash, you feel okay, and then by day 3, the cravings are really intense and you just can't get through to day 7 to actually start putting in place some of the other things that you wanted to do with your life. And traditionally, we just use something like diazepam to help people kind of relax through it. So we're going to be trying a decrease in dose regimen over 7 days of lisdexamfetamine, initially in the inpatient setting, because that's where some people go to help with methamphetamine withdrawal. So we're going to run that as a randomised control trial as well. The aim of that one is just to treat the symptoms of withdrawal. The aim isn't actually, we will look and see if it changes people's frequency of use and other health and wellbeing measures, but the main thing is just to see if it actually treats the symptoms. Yeah. It helps people get through to day 7.
Excellent. Looking forward to seeing that one. So what would be the primary endpoint for that then? Would that be sort of
withdrawal? Withdrawal. Yeah, over 7 days. Yeah.
We're getting lots of questions coming through. So there was one around, given the poor attendance at psychosocial intervention sessions, it would be interesting to compare outcomes between Lisdex and placebo if more sessions had been attended. Yeah.
You mean the relationship between frequency of attendance and the outcomes? I don't think we have enough people to do that kind of analysis. We are now doing another analysis looking at what predicted good outcomes. So whether frequency of use or whether age or duration of use or other factors, social supports, were associated with better outcomes or not. But the attendance, we didn't see anything with the psychosocial interventions between the groups. There was no difference really, unfortunately.
Mark's asking what you think is the biggest reason for the dropout, that sort of reduced face-to-face contact during those COVID months or years, reduced income of participants.
Again, because people had dropped out and we couldn't ask them. I don't know, so I'm making this up. I think it's very demanding. We're recruiting people that are using methamphetamine almost every day. It's very demanding to stay in a trial for that long. The trial procedures are really quite demanding, and I do think that having this alongside contingency management of some sort can help. And I know that in some US studies, they actually pay people for every part of the trial. So taking the medication, coming for the interventions. So something like that can actually help people stay engaged might help. I don't really, it may be the chaos of COVID. We really don't know. We didn't see a difference between before and after COVID. So I personally think it's just the demands of being in a trial because, as I said, nearly every one of these trials sees high dropout, except the one in the States where they pay them.
And they can use contingency management.
Yeah, you can call that a sort of contingency management, and they certainly had very good retention in that trial.
Yeah. So would it show in a drug screen, urine drug screen?
We could have set up a urine drug screen for the Lisdex itself. So 2% of Lisdexamfetamine is excreted unchanged in the urine. Very, very expensive.
Right.
And we thought let's just see if it works and ask people if they took the tablets.
And is it contraindicated for anyone with schizophrenia or an ABI? Could it be used in those contexts?
We didn't exclude people with schizophrenia or bipolar disorder. We did exclude people with a current psychotic illness because, yes, it will. The product label says it can cause psychosis. So we do need to be very careful in people with histories of psychosis and particularly with histories of schizophrenia.
Yeah. James Gooden, and actually when you presented your data on ADHD, the prevalence of 40% prevalent or screening for ADHD, it made me think of the NCRED funded study that we did looking at our neuropsychology attendees who had a high, particularly for the methamphetamine clients, that they had a high proportion of them ADHD type symptoms. And James is asking, and this is more of a comment, I think. I'm wondering if the data was collected on and what proportion had a formal diagnosis and how many had never been assessed based on their symptoms.
A formal diagnosis of childhood ADHD? Or
no, just
current ADHD. So we didn't. The problem with that, we didn't, because the problem is it reflects access to care and intervention more than it might reflect anything that's there. So that's why we just decided to do that very simple screening of childhood symptoms of ADHD. And I know the Norwegian group is using a much more comprehensive diagnostic tool for ADHD in the people with the stimulant use disorder. And so I think I think there's more work to be done in that space, looking at coexisting ADHD and stimulant use disorder. We just want to be able to describe the sample at this stage in this first trial.
Yeah. Sorry, what was the BPAD condition? Oh, the BPAD conditions, was it stable and treated?
Yeah, so to be eligible for the trial, people did need to be stable when they came on the trial. Yeah. And
they didn't need to come off any SSRIs or any other medication?
That's a good question about the SSRIs. We did, there's a theoretical kind of relative contraindication for being on SSRIs, and so not for the BPAD, but for people that might be on SSRIs for mood disorders. We see that commonly in people with methamphetamine use disorder. We did talk it through with people about whether they wanted to come on with the SSRI or just be monitored closely once they're on it. Some people elected to come off it before they came on, but that was people with mood disorders, but no significant bipolar or suicidality.
Right. Well, I think we've got through most of the questions. So, unless there's anything else you wanted to comment on, or
no, I'm just looking.
Okay. I think we've covered a lot of ground, and I'm extremely grateful for your time, Nadine.
Okay.
Such an important study, and we have so much to learn from it. So thank you again. And thanks to all of those attending online. And we will be back next month. I think it's end of July on the 30th. And the speaker will be Claire Slattery, talking on using law to reduce the cancer burden of alcohol. So we'll see you then. Thanks very much for your time today. Bye.